they have looked at screening, and they have found that you can actually pick up a cancer early and prevent that or decrease the risk of death from cancer. However, the problem is that you also um, it leads to a lot of procedures where you remove ovaries to rule out cancer. So it picks up some abnormalities in the ovaries that are not cancer, and that leads to a lot of treatments like surgeries and other treatments that can have bad effects on people. So because of that risk-benefit analysis, still is not worth doing full-scale screening yet for ovarian cancer. So that we got to get better at that. And there's actually some other studies going on with other blood tests other than the CA-125 blood test. So combining it with other tests looking for other proteins in the bloodstream that may actually help us pick up somebody at risk for ovary cancer earlier.
So the study you're talking about is a 2008 study, MD Anderson, looking at 3,200 women, looking at the CA-125 blood test, which you can get a sample of blood, and following them. Some were followed, and about 1% truly were very high risk and needed to have their ovaries removed. And they're trying to do a 200,000 woman study coming out of the United Kingdom in the next few years. Now, there are other tests which are much more expensive, the BRCA1 and BRCA2. So tell us a little bit about that.
So BRCA1 and 2 are genes that we all have. They were discovered actually in the mid-90s and the late 90s. BRCA1 was discovered in 1995 and BRCA2 in 99, 2000. These genes, if mutated, so if we inherit an abnormal copy from our parents, if they're mutated, they can lead to the development of cancers. So people with this gene mutation have a probably 70%, 70 to 80% chance of getting breast cancer in their lifetime and a 40% chance of getting ovarian cancer in their lifetime. Now, that number is different for BRCA1 and BRCA2, but both of these gene mutations have a very high risk for women. In addition, BRCA2 mutations actually have a very high risk for men developing breast cancer as well. So there's many other cancers associated with these gene mutations, and we're learning more about it all the time. Now, currently, there is a blood test to pick up these gene mutations. So it's an expensive blood test, but if we get the blood test in the right patient, in somebody who has had other family members die from ovary or breast cancer, we very often can help to identify women who do have the gene mutation. And then once we identify them, it leads us down the road of doing many other things to help them help prevent them from getting breast and ovarian cancer, which is very important. And this has gone a long way in terms of our understanding of cancer and in our understanding of how to prevent cancer in certain groups of women. Specifically this group of women who actually inherit the gene mutation.
Have they found out any ethnic specific things with the BRCA1, BRCA2, and ovarian? We know that it happens primarily in white women, ovarian cancer, whereas leading cause of death in Hispanic women in cancer is breast rather than lung. So have they looked into that?
There's a lot of studies regarding ethnicity in BRCA1 and 2 expression and disease. One area we know in the ethnic population, the Ashkenazi Jewish population, there's actually 3 specific mutations in BRCA1 and 2 that are much more likely to be inherited in Ashkenazi Jewish population. So we have if we have patients who are of the Ashkenazi Jewish ethnicity, it's very important for them to be screened for these 3 founder mutations because they are even at a much higher risk of inheriting these mutations. We're looking at some Asian populations, the Hispanic populations. We're looking at all of these areas to find out if there are specific mutations specific to those populations. And again, I think this is a very big area of research, and we'll probably learn a lot more in years to come about this. Right now, the most important thing about these gene mutations is that we want, it can lead to interventions that prevent breast and ovarian cancer. Specifically, risk-reducing surgery, such as preventative prophylactic mastectomies or prophylactic oophorectomies. In other words, getting the breasts or ovaries removed before they develop cancer, is a very big intervention. It's a very serious intervention that you need to enter into very carefully with patients. but can be important as a risk preventing, as a cancer preventing mechanism.
So, for example, if a 35-year-old woman has a family history of breast cancer and she comes with BRCA1 positive, what would you say? And she has the symptoms of 6 months of bloating, pelvic pain, and bowel movement changes.
So these patients are very high risk. So depending on their exact family history, it may encourage the doctor basically to order the BRCA1 or 2 test, or to refer them to a genetic counselor who can go over their family history very carefully and determine their risk and the need for the blood test. So that's one aspect that comes up. This patient who has symptoms and may be in this higher risk group certainly would warrant further intervention with an exam and CA125 and ultrasound. If the patient actually was found to have the mutation in the gene, the National Institutes of Health recommends that women at age 35 or when childbearing has been completed actually have their ovaries and fallopian tubes removed surgically. This can be done with a minimally invasive approach as an outpatient, and is really the only recommendation that has come out from the National Institutes of Health and National Cancer Institutes in relation to preventing ovarian cancer in this very high-risk group of people. Now, breast cancer is a different story. So with breast cancer, we have high-resolution breast MRIs and mammograms that can be done every 6 months to help prevent or pick up these cancers early. So patients can either do that, which is a known surveillance mechanism that works, or they can undergo a prophylactic mastectomy, which is surgery to remove the breasts to prevent the development of breast cancer. And that's certainly something they should talk about with their breast surgeons or oncologists.
So currently, if, let's say a woman is 35, is BRCA1 positive, but family history remotely positive, like grandmother, like one generation removed,